This is Dr. Kilman. Welcome to this provider update on Medicare risk adjustment. Once you have completed this video, please follow the instructions so that you can obtain credit for your attendance. I would like you to imagine a world as a provider where your reimbursement was based not just on a 5-digit number you submit to an insurance company, but reimbursement that truly reflects the complexity of the patients we serve. Medicare, as well as other payers, are making progress towards this end as we move further into the world of value-based healthcare. So I ask you, when Medicare looks at your patients, what do they see? They see our patients through the lens of our documentation and coding. Are we painting an accurate picture? Do they see an accurate painting of our patient's severity of illness? Or do they see an inaccurate picture of health and wellness? I want to give you an overview of this current process and also give you some helpful tips and tools so you may position yourself to take advantage of these changes. Medicare and other value-based payment models are now assigning risk to their beneficiaries. This risk-adjusted factor, or RAF score, is composed of age, gender, disability, and diagnoses. Let's focus on these diagnoses. Hierarchical conditional categories, or HCC scores, are actually categories of ICD-10 codes with a specific weight. This risk model includes categories that best predict future Medicare Part A and B expenditures. There are combination codes for disease interactions. You actually only get credit for the one code within each category. So if you were to choose diagnoses, multiple diagnoses within a particular category, you would only get credit for one of those diagnoses within a category. And please note, not all ICD-10 codes are assigned to a category. The average health Medicare patient for the nation would have an average score of 1. So the higher the score, the more severity of that patient's illness. And patients get a clean scorecard every year. They call this the Medicare miracle. So if someone has an amputation, which has been coded in the past, but it is not coded in the present year, then Medicare views that patient as if they no longer have that amputation. So why would you have a lower HCC score? Either you have a healthier population, or it could be due to lack of documentation, inaccurate coding, lack of coding, or that patients are not evaluated. This will have a tremendous impact on payment, both MSSP, bundles, and now in the current model with MACRA, and specifically it does affect ACOs. So let's look at a patient. On the far right, we will say this patient was evaluated twice in the past year, both for acute conditions such as a UTI or sinusitis, but no comorbid diagnoses with HCC scores were coded. Therefore, her only weight for her RAF score is from her age and her Medicaid status. And you see the impact of this risk adjustment on that bid rate for, let's say, a hospitalization and the impact of the payment. In the middle example, she was evaluated and her diabetes was addressed, but the lower weighted, less specific diabetes code was used, as well as the unspecified coronary artery disease code, which has no weight. Though her RAF score is slightly increased, it still has a tremendous impact. In the far left column, the provider used the more specific diabetes with CKD because they had assessed that patient's GFR and determined that it was decreased. They also coded the insulin use code because this patient is on insulin. They noticed that she was on a long-acting nitrate for her angina symptoms, and so they used the more specific CAD with angina code. They also coded her CHF, and because of that, they got a disease interaction code between the diabetes and the CHF. You see this more than doubles this patient's RAF score, and that final payment is more than double the previous amount. Though these numbers are illustrative, it does show a very real impact that this has on our system. Let's look at Centricity and show some new tools we have to help with this process. In primary care, you are used to seeing this current HPI page. As you scroll down, we will now have a new section titled Long-Term Problems and Plans. So this will allow you to have a long-term ongoing problem list, which you can pull forward from previous notes and modify so that it may evolve as the patient's health status evolves and as you document the meat, as we call it, how you monitor, how you evaluate, assess, and treat these patients. Below this, you will see a new section which is basically a buffet for these high-impact HCC categorized diagnoses. I want to highlight a few of these sections. The first is CKD. You see that there is diabetes with CKD, and below you can see how you can easily identify the patient's GFR, when their last urine microalbumin was taken, and if they indeed do have a decreased GFR based on the criteria, you can then easily add that code. This would allow you to also use the more specific diabetes code. You see there are two diabetes categories. The lower weighted category does include the code for the long-term use of insulin, which may be used if they are on insulin. If they were to have hyperglycemia or polyneuropathy, you can easily add these codes from this buffet. You'll also see the obesity section. If a patient has a BMI greater than 40, they do get an additional HCC score, but you must code the morbid obesity. Malnutrition, this may not be frequently seen. It is seen to some level, and it is a very highly weighted code and important that we code it accurately. This section will allow you to see the patient's last weight, today's weight, the difference, and if by chance they did have greater than 10% over 6 months or greater than 5% over 3 months, you can check these boxes, and we have below the aspirin criteria, and if they were to have these symptoms, you could then add this to your documentation, as you will see here, and then you can easily add that diagnosis here. Other weighted categories include thrombocytopenia, congestive heart failure, arrhythmias, angina. It's important in CAD if a patient does have some type of other angina, such as they are on nitroglycerin they take intermittently, or they are on a long-acting nitrate or Ranexa, then it's very appropriate to use the CAD with other angina code. In stroke, please note that it is important to code the paresis that they have. The paresis is the weighted category, not the actual code for the infarct. Under vascular disease, please note the atherosclerosis of aorta. This is often seen on chest x-rays or CT scans. So if this is noted, please use this code and chart what measures are being done to prevent progression. You have your ostomy section, drug and alcohol, psychiatry, rheumatoid arthritis, and your amputation status. So we have selected some more common codes that are in these HCC categories and provided a buffet so that you may get these onto the chart. But again, they must be attached to the E&M code and get to Medicare in order for them to make a difference. In addition to getting the diagnosis added to the chart and attached to a claim, there must be adequate documentation as well, how you are monitoring, evaluating, assessing, or treating these conditions. In summary, to have an impact, these diagnoses must be on the claim. You can attach up to 12 diagnoses per claim. Please attach all comorbid conditions for the primary diagnosis for which you are treating these patients. We need to have all comorbid conditions coded yearly, as the scorecard is erased each year. We will be providing you a dashboard showing your HCC averages. This will be helpful in assessing your progress in this matter. Thank you for your time in this educational activity.